to Moodle, there's going to be a lecture that says blood vessel lecture with sound. And that's, you can go ahead and just turn off that one. I did think that I thought that I had the Word document on there that was blood vessels to know. They're the same thing, and the PowerPoint is probably the better one because it actually points to the vessel that I'm talking about. It's not just a list of vessels. And it's with sound, so it is narrated by me, which I would think would be annoying. And I can also point out one that it says blood vessel lecture with sound and laser. So it actually has a little diagram that says this is the one I'm pointing to in the direction that it goes. So it's totally up to you. I will try and post both on Moodle, but it's this one that you're going to want to print off. Okay, that'll be the one that I'm going to be doing. Well, it probably won't be the one because I don't want the sound because I'm going to be the one talking. But we will do that tomorrow. Okay, so we're still going to do heart. I'm going to go over heart today, get into a certain point, and then, like I said, I don't want to give us too much time where I don't have enough time to, at the minimum, give you this day before finals. Okay, but I definitely want you to have at least 2 weekends to start going over this material. And again, I wouldn't put it off. It's another aspect of studying. This is the stuff that's just rote memorization. It's just going over it, over it, and over it, and over it again. Okay, so you do have a blood vessel practice. Okay, so there's going to be something right here when you open this document that's going to ask you, okay, you're starting at this vessel and you're going here. And then there's the answer. Now, I will do as many of those as you want. I'm not going to send you 18 a minute at a time. I will send you one at a time. And they will not always be two separate ones, but if it's in an email, or if it's, whether it's an email or it's a Word attachment, I'll put the thing at the very top, and I'll put the answer down at the very bottom so that you don't have to look through and cheat. You can fold it over and try and answer it and then open it up and take a look at it, okay? And again, I'll send you as many as you want. So I finished that one, can you send me another one? And it's that kind of practice, okay? So, I mean, there's an infinite number of ways that I can give you a one question. Now again, this is going to be worth, out of 100 points, anywhere from 10 to 12 points. A pretty significant chunk. Okay, most people actually do fairly well on it, so I wouldn't, get too upset about it. But it's definitely something that you don't want to put off start. All right, heart. So hopefully everybody knows the heart is not actually shaped like this. It's not like a box of chocolates. It's shaped actually like your fist, and it sits in the chest. Most of it is on the left side of the sternum. So it looks from this standpoint here. Again, portion of it or most of it is over here. It goes from about the second intercostal space, so the space between the ribs. Some actually will say the second rib itself, and it goes down to about the fifth rib or the fifth intercostal space. Again, that's the general area. So when we look at the heart, it is named in a funny way. Okay, the apex of something is generally the top portion of it. Just like we used to, the term that I talked about with the eyeball, where we had fundus. You know, fundus generally means the top of a structure. The fundus of the uterus, the fundus of the stomach. In the eye, the fundus was the posterior wall. Here, an apex again means the top of a structure. The problem is that the top of the structure, the apex of the heart's down here. Okay? The heart's actually named as if you were laying in the supine position. Okay? This is also one of those things that's very difficult to grasp unless you really are into 3D structures when you're talking about the embryological development of it, because it starts to twist on itself and go from there. The heart is basically two pumps. Okay? Two biological pumps. It's under a pound as far as its weight goes. It's going to be based off of your size. It's also going to be based off of your athletics. So if you're somebody who is highly conditioned from an endurance standpoint, you're generally going to have a bigger heart than somebody who is not. It's a muscle responding to training, and it gets bigger from that standpoint. when we talk about, so the apex was that structure that was down here to the side. The base is actually the posterior aspect of the heart itself. So again, when you think of the base, you're thinking the lowest part. Well, here the lowest part is the apex. The apex is important because it shows where we have, that's the primary spot for our left ventricle. And our left ventricle is probably the biggest of the two pumps, okay? In other words, it's moving blood in a forward direction. That's what pumps do. We don't want things coming back. We always want them moving forward. So we have what's referred to as a point of maximal impulse or point of maximal intensity. I'll show you from the diagram here. So here is where the PMI would be. And you can all feel your PMI. All you're going to do is just take your hand and put it somewhere around here, and you're feeling for the point where you have the strongest impulse, where you can feel the contraction of the heart. Okay? This is beneficial because if there are structural things that are going on inside the chest, the PMI can be moved. Okay? So if you've never been in the back of an ambulance, it's very difficult to take your stethoscope and listen to sounds on patients. It's extremely difficult if you've got a baby that's, you know, this big, and you're trying to listen to see if there's something going on in the lungs or something going on in the heart. Well, if I know where the PMI was, I can actually feel that. And then if something structurally occurs inside the chest on transport, the PMI is going to shift. So it's just another tool from a diagnostic standpoint. This is if we kind of cut the top of you off so that you can get an idea. This is T8, so you can see the different chambers inside the heart and the lungs. And then that's just a shot without the ribs so that you can see its structure. Again, we're going to be going over all of this. Now the heart sits in what's referred to as the mediastinal cavity. The mediastinal cavity is one that's essentially bordered by the diaphragm on the bottom, the lungs on the side, and it actually goes up farther. So it's where we have what's referred to as the great vessels in the heart. We also have the trachea, we have the esophagus, so that's all in the mediastinal cavity. Now the heart, sorry about that, exists in what's referred to as a pericardial sac. Now, in A&P1 we talked about serous membranes, and there were 3 serous membranes in the body. Remember, when we talk about cutaneous, we talk about membranes in general, we have cutaneous membranes, which is our skin. We have mucous membranes, which is things that are on the inside of the body but are open to the atmosphere. So your mouth, when you open your mouth, that's a mucous membrane. It's exposed to the outside. Eyes, nose, GI tract, vagina, urethra, anus, those are all considered mucous membranes. Serous membranes generally surround structures, and their primary goal is, one, to hold things in place, which we'll talk about in A&P3, but the second one is it decreases friction. Okay? So the 3 serous membranes are the peritoneum, which are in the stomach, or in the digestive system, to be more accurate, the pleura, which surround the lungs, and the one we're going to talk about today, which is pericardium. So the pericardium is a serous membrane. All serous membranes are 2 layers. And they're all named exactly the same. There's a superficial layer, there's a deep layer. There's a layer where it surrounds or it's attached to the cavity that's in. That's the more superficial layer. The deep layer is generally surrounding the organ. The superficial layer is referred to as the parietal layer. And the deep layer is referred to as the visceral layer. And then they're named for the serous membrane that we're talking about. So since we're talking about the pericardium, it would be the parietal pericardium. If I'm talking about the deep layer that actually lines the heart itself, it would be called the visceral pericardium. Now, it decreases friction. So I'm sure everybody at some point has taken 2 microscope slides and put fluid in between them. Now, can you pull the microscope slides apart? No. Can I move them like this really easily? Yeah. That's what serous membranes do. So we have fluid in there, and it's referred to as pericardial fluid. You have about 15 to 20 milliliters of this fluid. It's called a serous fluid, is the general term. Because this structure is not like skeletal muscle. It's not like your legs. When you go to bed at night, unless you have restless leg syndrome, your legs aren't doing a whole lot of work. Okay? This doesn't stop. If this stops, what happens? You die. I mean, it's as simple as that. It just does not stop. So from that standpoint, it's got this constant movement inside that pericardium. And we want to make sure that it's not getting irritated as it rubs up against surrounding structures. Okay? And again, this is not a 3D picture, obviously. So keep in mind that this pericardium is going to surround the whole entire heart with those layers. Now here, it's a little different than what we have in the other two serous membranes, in that we actually have a thing that is not part of the serous membrane, but it kind of fools you into that process, and it's referred to as the fibrous pericardium. So it is actually the most superficial, but it's not part of that two-layer system. So directly underneath the fibrous pericardium, we have the serous pericardium. So it's the structure right here. This is the parietal pericardium of the serous membrane, bless you. And then it comes over, doubles over, and then it adheres directly to the surface of the heart. And it's referred to as the visceral pericardium of the serous membrane. And then the fluid would exist in there. So probably the best description of a serous membrane is if you were to take a fairly large balloon and a fairly flexible balloon, not blow it up completely, and if you were to take your fist and push it in. You would have the part of the balloon out here that's not coming in contact with your organ. That would be the parietal layer. You then have part of the balloon that is coming in contact with your fist. That would be the visceral layer. And then you'd have the distance between the parietal and the visceral, the outside of that balloon and the part of the balloon that's touching your hand. That is where they have the fluid. Okay? Now there are some disease processes where that fluid would decrease. And sometimes it only decreases in a spot of the pericardium. So when you go to auscultate, when you go to listen to someone's heart, depending on where you're listening, you might end up with what's referred to as a pericardial rub. So when you hear somebody described as having a pericardial rub, it's, if you've ever watched The Wizard of Oz with the Tin Man when he moves and he squeaks, okay, that's called crepitus. That's what it sounds like. Okay, it sounds kind of like metal on metal in a way. I will tell you, never write it down if you didn't hear it. So that's probably one of the biggest things is like, well, the physician was in before me and they said this for breath sounds, and it's like you're listening, it's like, yeah, that's not here. I don't care if I'll get your question like if it's physician or not. If you don't hear it, don't write it down, because they could have been wrong. And I've had somebody who was like, God, I've never heard this before, and this was when I was a student, and they were like, it's there. So we went back down with an instructor and listened, and it was gone. So again, you don't take just simply what someone said before you. You listen yourself, and that's what you want to write down.
What makes it sound like metal on metal is
it's the fact that you now have a decrease or an increase in friction because that serous fluid is no longer there. So it's things moving and rubbing past each other.
even though it's like a soft tissue?
Yeah, because it's actually a connective tissue. And connective tissue isn't as soft as if it was a mucous membrane. So now there are times where because of trauma or because of a rupture of something, this sac can actually fill up more with either fluid or blood. Okay? When that happens, if you think about it, I now have these two pumps right control left ventricle, and they're going to be pumping. Well, if I start filling up this outside with blood, it's going to start pushing down on the heart. If it pushes down on the heart, do you suppose that those pumps are going to be able to push blood out? No. So this patient ends up having what's referred to as a cardiac tamponade. I think I have. So there's the heart beating, and again, it's going to be sitting inside this pericardial sac where we normally have fluid. And let's go a little faster here. So injury of some sort. So the fluid can come from outside. More than likely it's coming from inside, or it's coming from one of the blood vessels that sits on top of the chest. So we would see this on somebody who had a coronary artery bypass graft or open heart surgery, and it's bleeding, so it bleeds into that sac. And when it bleeds into the sac, it starts to push down on the heart. And when it's pushing down on the heart, then the heart can't beat. It's still beating, it's still trying, it still has electrical activity, but blood's not going round and round. And again, what happens when blood doesn't go round and round? You die. So at this particular point, what would happen is there's a variety of different things depending on where the situation is. So you can take this really, really, really long needle and you stick it up right underneath the sternum until you get to the pericardium, and usually we have a little attachment on there. Now we have ultrasound, so it makes it a little bit easier. You put an EKG wire on there, so as soon as the metal of the needle contacted the heart, you would see a change on the EKG, so you knew you were in the right place. And then you would just start pulling blood off. The problem is you don't know if you pierce through the heart and are actually pulling blood from the inside of the heart. We're wanting to pull blood from the outside of the heart. The easiest way is when you had a patient who had open heart surgery, because then they had what's referred to as a sternotomy, where they've had sternal wires, and so they bring the chest back together. And the nice thing is you see that occurring on the monitor. I mean, you can see this when we have, because if you've never seen somebody who had open heart surgery, we basically will stick tubes in every body orifice, and then we create more orifices. So you have lots of tubes, but there are all sorts of monitoring and catheters inside the heart. So you see this coming up, and then we just simply open the chest, cut the wires, and go in and actually evacuate the blood from that standpoint. So you actually get to see the heart beating and that type of thing.
I was just wondering if the sac on the video is close to what it is compared to the heart in the
What do you mean? That's just an animation, so.
I guess my question is, how big is the sac compared to the heart, like around it? How much space is in between?
Not very much space.
So it's
If you think about pericardial fluid, there was about 10 to 20 milliliters of fluid in there. So when you think about it, we have the same spot, same thing in the lungs. And it's referred to as the pleural cavity, or the pleural space, and it's filled with fluid, and it's about the same amount of fluid. So if you think about a 3-liter pop bottle, which I don't think they make, but think that's the size of your lungs, or could be, and there's only 25 cc's of fluid that surrounds it. So not a whole lot of space. It's not one where it's like, oh, you can move a small family in there. It's fairly tiny.
Where did you say the fluid was located, like in the layers? The serous fluid?
It's between the parietal pericardium and the distal pericardium.
When people have chest tubes, are they ever draining fluid from them? Yeah.
So, but they're usually lower. If I have fluid in my pleural space, then the chest tubes are placed down here. If I'm evacuating air, then they're placed up higher because air rises fluid. And then if you're talking about, I mean, this is a side note, but different thing. But what you have is 3 chambers. This is your water spirit chamber with just bubbles. This is your suction chamber. This is the collection chamber. So when you're draining fluid, that'll be where it's draining from. So yeah, it's fat patient that has pleural effusions, open heart surgery, it'll be draining lots of fluid. All right, so that's surrounding the heart. So remember, heart sits in the mediastinum. Surrounding the heart is the pericardium, which is a sac, not so much a cavity, but sometimes we get a little lazy and I call it a cavity. That's made up of 2 layers. We've got the parietal, which is the more superficial one, parietal pericardium. We have the visceral pericardium, and then on the inside we have that pericardial fluid. That, by the way, is how I would study. Okay? I think the more responses you give, that's the best way to go. So if somebody's asking you a question, they're like, where is the visceral pericardium? I hope they don't talk like that. But then you can kind of say, it's right here, and then it's surrounded. Again, the more response, the more you can include in your answer. Not on the exam, but the more you can include your answers you're studying, you're putting things back, you're repeating things over and over and over again. Probably one of the best ways to learn is to teach. So once you get the information down, or you think you have your information down, you know, stand in front of, you don't have to stand in front of anybody. You can be in your bedroom, talk with Kat, have your notes handy, and just say, I'm going to talk about the heart today. The heart exists here. And then if you get stumped up, you have your notes here, and you stop, and you go, okay, and then you take a step back. Because as you're teaching it, you're saying it, you're hearing it, and you're having to think about it. And that's probably one of the best ways to really put the information down. But again, that's how I would do this. And I think I've already talked about efficient ways of studying in that, you know, when I get people that say, well, I've got to cram all weekend long. If you study the correct way, I wouldn't study longer than an hour. Get up, leave, walk the dog, go to the store, do the laundry, what have you. Pick up a normal book. Come back, study for another hour, but I would spend the first part of that reviewing what you did in the first hour. And if there's something that seems to be a stumbling block, write it on a piece of paper. Then study, go away. Come back, do a third hour. Review the first hour, review the second hour. And that's how it works. Okay? So it's not just, well, I have a test on Monday, so I should probably start studying. That's how you lose it, especially during an accelerated process. So now we're going to talk about the heart itself. The heart has 3 layers to it. Okay? One of them I've already talked about. The visceral pericardium is referred to as the epicardium. It's the top layer of the heart. Epi means on top of. We have the myocardium. And again, this is why I say it's kind of important when you start taking that medical terminology, because it allows you to start guessing words. Myo means what? Muscle. Cardio means heart. It's the muscle of the heart. This is the part that actually contracts, that is part of the pump, that moves blood in a forward direction. And then we have the endocardium. Now, I told you that there are a lot of cells. Cells essentially make up the inside of blood vessels. All right? And we call those endothelial cells. The description of them, the category that they fit into, are simple squamous epithelial cells. Remember, simple meaning one layer, squamous meaning they were more of a squish standpoint. But when we put them in a different place, we call them different things. Here we're calling them endothelial cells, or endothelium for the tissue. Now they're in the blood vessel, but they then continue down and form the inside layer of the heart. Okay, so the endocardium is made up of endothelial cells, which is a continuation of the blood vessels that either bring blood to the heart or take blood away from the heart. Now I told you that the heart is essentially 2 pumps that are going to be pumping blood in different directions. Okay? There are actually 4 chambers. All 4 chambers at some point will get smaller. They will contract. Okay? But when we talk about the heart being a pump, we're really talking about the chambers on the lower part, which are our ventricles. And I'm going to talk about the ventricles. Here I'm talking about the atrium. Okay? These aren't the pumps of the heart, but they do contract. Okay, these tend to be more receiving vessels, so to speak. Now, when you look at the surface of the heart, and she does herself a little bit of a disservice, so let me get a picture where she actually does the disservice here. So when you look at the heart with everything removed, the chambers are on top. Now, when you look at this heart, you actually cannot see the atrium. Okay? There is nothing on the surface that designates X marks the spot. This is the atrium. Unfortunately, when you look at this, what does she call this?
Atrium.
The right atrium. Okay, that's not the right atrium that you're looking at. These are referred to as auricles. Okay, and I think probably the best description, I think your book uses it, they're kind of like dog ears. Okay, they're just an extra place to store excess blood. Okay, and you have them on the surface of the heart. So what I do know, understanding the anatomy of the heart, is that the atria sit below this. So this is an auricle. And again, just structures that hold excess blood. Now, we talk about the atrium. Let me show you another picture here. Open it up. We have a structure that is delineated by what's referred to the C-shaped structure on top of it. It's referred to as the crista terminalis. And if you picture, so just say this is the right atrium right here. The crista terminalis would sit like that. So anything that's in front is the anterior portion of the right atrium. Anything behind it is the posterior. And there are some differences as far as the structure goes. The anterior has these muscles right here, and they're referred to as the pectinate muscles. Okay, the pectinate means cone. And when you look at them, and you're going to be able to see them, I can't remember if they're on the sheep heart or not. They look like a comb, like somebody actually just took a comb and combed the muscles so they're in a nice straight line. The posterior wall does not have pectinate muscles. The left atrium does not have pectinate muscles. The auricles have pectinate muscles. And they aren't really quite sure why. It might have something to do with the velocity of blood, the amount of blood storage, that type of thing. But that is the general setup from that standpoint. Now, in the medial wall, so the right atrium and the left atrium are separated by what's referred to as a septal wall. Okay? We're going to see the same thing in the ventricle. Sometimes it's referred to as an interseptal, intra-atrial septum. In other words, between the two. But there is a small little divot in there. And that small little divot is called the fossa ovalis. Now, the fossa ovalis is a remnant. So one of the things that occurs is when the baby is still inside mom, there's a lot of things that its organs don't have to do because it's being accomplished by mom. So this is basically, if you ever have to take care of kids that have cardiac surgery, that type of thing, and you have to just explain things to mom and dad, sometimes just the easier diagram is what works. And everybody does it slightly different. So right atrium, so what happens is, when the baby's still inside mom, blood comes down. Normally this is going to go to the lungs. Well, the baby's lungs are filled with fluid. So it meets resistance. So it's going to take the path of least resistance, and I'm going to show you two of these throughout this lecture. One of the paths is in between right there. It goes from the right atrium to the left atrium. There's a hole in that wall, that septum. Okay, the interatrial septum. So this is referred to as a patent foramen ovale. And again, one of the things you're going to find, very lazy. We're very lazy people. So we call them PFOs. So if you work with kids, if you work with neonates, when you get a report, patient has a PFO. We're not going to say the whole thing.
This is the,
This is inside mom.
okay.
Haven't popped out yet. Okay. And then what happens is that during birth, where the baby's organs start to have to take over, it starts to switch more to an adult circulation. So then essentially we're going to have a pressure change, and this seals itself off. Basically a one-way valve.
So the PFO happens when that doesn't seal itself off.
No, when it's open. So whenever you have this open, it's called a PFO.
Even if the baby's not born yet.
Yep.
Okay.
Yep. So now, nothing can go through. Well, over time, this basically shuts the door, and it's now an indentation. And that indentation becomes the fossa ovalis. So, you know, to help you make the connection, look at the names. Fossa ovalis kind of sounds like foramen ovale. Patent just means open. You're going to hear that a lot. So a patient have a patent airway. Is their airway open? That's all patent means. Okay? Now, I will tell you this does not close completely in about 25% of the population. And it's usually not a big deal because the way that this works is, since it's kind of a door being shut, is that the pressure in this side is greater. So it's basically pushing, it's like closing the door and somebody standing out there and pushing the door on. But then if somebody gets sick, it'd be the equivalent of everybody coming in from that back door pushing this door open. So if somebody gets a sick heart for a variety of reasons, the pressure becomes greater here and pushes on that door and opens the door. And now you have a connection again that you shouldn't have. So 25% of the population, that door is not permanently closed. And it's not a problem unless they get a sick heart, unless they have structural or fluid changes that exist here. And then it has the potential of pushing it open. Yes, ma'am?
Is there a certain name for that condition, like when it doesn't close all the
No,
way?
there's a variety of different things that can, I mean, it's still called a patent foramen ovale. But you'd be able to see it on echo. So you actually will, you can take air, it's a bubble test, and you can inject it, and then on echo you can actually see it cross over. So,
Is that considered like the leaky valves? Wait,
Um,
explain.
incompetent valves can lead to that. So they in and of themselves wouldn't necessarily cause it, but if they're not fixed, they create another problem that would cause it. Now, because this is a pump, or not a pump, it's a chamber, and I want to make sure that we have one-way movement of blood. I don't want blood coming backwards. That defeats the purpose. So we're going to stick valves in between all of these chambers so that that does not occur. So the valves are going to be named for their location. So I have a valve that exists between the right atrium and the right ventricle and the left atrium and the left ventricle. They're collectively called, and again, think of the name, atrioventricular valves. They're telling you that these valves exist between the atrium and the ventricle. Now, they have different names based off of the side of the heart that they're on. So the one that exists between the right atrium and the right ventricle is referred to as a tricuspid valve.
They run up and
No, they exist between the atrium and the ventricle. It's a valve.
Okay.
So tri meaning three, cusp meaning leaves or segments, if you will. So it's three segments that basically come together and they stop the blood. They prevent blood from going from the right ventricle back up into the right atrium. Because again, that would not be forward movement of the blood. Now, the one that exists between the left atrium and the left ventricle is referred to as a bicuspid valve. Why? Because it has two cusps instead of three. Now, the other name for it is called the mitral valve. And you should probably know both. Mitral tends to be used a little bit more clinically than bicuspid valve is. So you might hear that somebody had an MBR, which is a mitral valve replacement. Now, probably the biggest thing is trying to figure out which is which. Okay? So I'll give you two of them. The one that I've always been taught, and I tend to teach, is that you are going to try something before you buy something. So when we talk about movement of blood through the heart, it goes from the right heart to the left heart. So your tricuspid will be the first valve, bicuspid will be the second. Now the one that your book uses mitral valve instead. And they make a point of saying that there's an L for the left side of the heart and RI and tri for the right side. Pick one, don't care. It doesn't even have to be this one. I'm sure that you can Google mnemonics for the atrioventricular valves and there'll be a bunch of them. Now, occasionally, these valves don't do what they're supposed to do. So I haven't got into exactly their function yet, but again, they are going to prevent blood from moving in a backward direction. So for the most part, they're generally always open. They're only closed for a short period of time. Okay? But if they allow for blood to go back up into the atria, okay, that's referred to as tricuspid regurgitation. It's referred to as regurgitation in general. Whenever blood's moving in a backwards direction, we use the term regurgitation. And then we just identify the valve that's not working. So you're going to hear terms like incompetent valves. Now, if they are floppy and they allow for the blood to go backwards, that's going to be a problem. Sometimes when I said that they're open most of the time, sometimes they're open but they're narrow. Okay, that's called stenosis. Anytime something is narrowing, it's called stenosis. And again, we identify the valve we're talking about. If it's the tricuspid valve, then it's tricuspid stenosis. And that would just put extra work on the heart. So when we talk about what types of things would cause that, yeah, if my valve was doing that, then it means that this heart's going to end up getting bigger and bigger and bigger, the right atrium, and more than likely it might kick that door open if you're one of the 25% of the people that didn't have it closed. So, any questions on the atria?
So if your patent for a valve doesn't close, like, is that like common? Do most people in the 25% know that they are in that?
No, they would have no idea until they started having other cardiac problems. Or unless something happened, and there are things that are picked up for a variety of things. I worked with a pulmonologist who played hockey. He took a puck to the back here, so the posterior ribs, your kidneys are going to be about T12, L2, L3, so they sit back here, and the rib protects it. He took a puck to his ribs, so he had an X-ray. They found a tumor on his kidney. That's the reason a lot of people hang up with the doctors. They just think one of these days is, the doctors just palpate you, and then one of these it's like, oh, you have a lump there. And then, you have have cancer and you're gonna die and everything's bad. And then you go, oh, no, I got a lump on that side too. Again, apparently as long as everything's bilateral, everybody's okay with it. Because you can't possibly have cancer on both sides. And if you're not one of those people, you might become one of those people as you start to go through your pathophysiology. And again, as I talked about the weird diseases with eosinophils, there's diseases that you had to have lived in this particular area and you had to have been there for this particular time, and it's got 15 symptoms and you've got one of those symptoms and you know for a fact you've got this disease. But I've never been there. Doesn't matter. I've got it. I'm sure there was a tsetse fly that came over, it was on the strawberries I got at Market of Choice, and it bit me, and at least welcome to my brain. So the ventricles, these are the pumps. So when we talk about the pumps, we're talking about the ventricles. And they sit below. Okay, they're the two chambers on the bottom or on the inferior side, directly underneath the atrium. Okay? Now, some interesting things about it when we look at the inside. The muscles are arranged in almost like a cavern. So a good description is when you're trying to compress things, if you had wet palms and you pushed your palms together and then you pulled them apart, you're still going to be able to pull them apart because you can generate more force, but you can tell that they were stuck together. Okay? That's a theory of why we have the inside of the heart, of the ventricles, have this orientation of this cavernous structure of muscle. And the name of it is referred to as the trabeculae carnii, or carnii. Okay? That's the name of the muscle. And it's more of a description of the muscle. It sounds like a romance novel. It's called The Crossbars of Flesh. And again, it's this orientation here. Now, there's another structure that's present there, another type of muscle. That's referred to as the papillary muscle. The papillary muscle are finger or nipple-like structures that project upward. So these are your papillary muscles that are right here. Now, they have a function. They're attached to the chordae tendineae, or tendinii, and that's these little almost guide wires that are right here. And they're attached to the cusps of the valves above them. So here you have the tricuspid valves, the three cusps. Each of the cusps is attached by two chordae tendineae, also attached to the papillary muscle. Again, it's going to play a very big role in how we regulate blood flow moving in a forward direction. Now, cardiac muscle is a muscle. Muscle responds to stress placed upon it. So more work, the muscle's going to get bigger. Now, when we look at a cross-section between the right ventricle and the left ventricle, what you're going to notice is, one, the overall setup. So here is the left ventricle, here's the right ventricle. Here's the ventricular wall of the left ventricle, here's the ventricular wall of the right ventricle. One, so if this was the the left ventricle, it's kind of set up like this. Okay? The other thing that you should notice is the size of the wall. Okay? So what you should think in your head automatically is, this is a bigger muscle, therefore for some reason, and we're going to talk about what that reason is, the left ventricle has to do more work than the right ventricle does. That's why it's a bigger muscle. Structure equals function. These are the types of things that hopefully you're starting to think about, so that when you're having a discussion with a physician or when you're having a discussion with somebody and from a science standpoint it comes up, well, why? Because I don't necessarily see it, but I can see that it's bigger. There must be a reason why it's bigger. Well, it's muscle. Must do more work. Now, just a real quick answer. This pumps blood just to the lungs. Very close. So if I'm in the right ventricle, I'm going to pump blood to that wall. If I'm the left ventricle, I'm pumping blood to the rest of the body. I'm pumping it out there. Which is a farther distance? Out there. Therefore, I'm going to have to work harder. When I work harder, my muscle gets bigger.
So the papillary muscle is attached to the chordae tendineae, but what did you say those attached to?
The cusps of the valve itself. again, you'd have 3 papillary muscles because on the right ventricle, because it's attaching to the tricuspid valve, which has 3 cusps. So the heart, when we really look at the gross anatomy of it, in other words, what I can see with the naked eye, is pretty simple, because we haven't got into the microscopic anatomy of the heart yet, which is where the anatomy gets a little bit more difficult. But we're still on the outside. We're just looking at the heart. These are the important structures that you're going to see. Okay? Now, there's going to be blood vessels you have to know. All right? We classify them based off of their location. We classify them based off of their function. We have blood vessels that are attached directly to the heart. Any blood vessel that's attached directly to the heart is referred to as the great vessels. Now, we have the superior vena cava. Sometimes you're going to hear people say vena cava. It's a potato-potato kind of thing. And it's bringing blood back to the right atrium. It drains blood essentially from the head and some parts of the chest, the thorax. There is not a valve between the right atrium and the superior vena cava. Blood just flows back in. Now, I have blood that's coming from the rest of the body, and it comes through the inferior vena cava and goes back to the right atrium. Yes, ma'am.
So the superior one's coming from the lung, is that what you said?
No, it comes from the head and some parts of the chest. And again, no valve present. So just as blood is coming back, they just simply drain directly into the right atrium. Now, we have a large vessel that comes off of the right ventricle. So remember, the right ventricle is a pump. I said you had 2 pumps in this heart. They're basically pumping blood to different areas. The right ventricle is going to pump blood to the lungs itself. Its purpose is to pick up oxygen. So in that instance, we have a thing called a pulmonary trunk. And from the pulmonary trunk, it divides into the pulmonary arteries. One goes to the right lung, the other goes to the left lung. Now, this is one of those areas that I'm not too nitpicky from a pure anatomical standpoint. You should probably know that there's a pulmonary trunk that divides into the pulmonary arteries right and left. If you want to say that the pulmonary artery comes off of the right ventricle, that's fine. As long as you understand that that pulmonary artery is going to go to both lungs. So pick one, don't really care. The more correct is a pulmonary trunk. It's going to divide into the pulmonary artery. Here I have valves. Bless you. I have what are referred to as the semilunar valves. And again, I'm going to talk about the function of the semilunar valves, how they actually contract, but they're right here. Again, preventing a backward flow of blood. Now on this, on the pulmonary artery, well, let me add 2 more things on it, and then I'm going to come back and talk about it. That way it makes more sense. So the pulmonary arteries would be right there. So they leave the right ventricle and they go to the lungs. So from the lungs, I'm going to have blood coming back to pulmonary veins. There are 4 of them. 2 from each lung. And they all go into the left atrium. There are no valves in the pulmonary veins. Now the last of the great vessels is going to be the aorta. It's going to take blood to the rest of the body. You have semilunar valves in the aorta, just like you do in the pulmonary artery. So out of the 4 divisions of the great vessels, superior and inferior vena cava, that's 1 division. Pulmonary artery, 2nd division. Pulmonary veins, 3rd division. Aorta, 4th division. 2 of them have valves, the other do not. So I have valves here and there. Now the point of the pulmonary artery is to take blood that needs to pick up oxygen, so it goes to the lungs. So how is it that it's called the pulmonary artery if it has deoxygenated blood? Remember, that's the term that I want you to use. Your book's going to spend time talking about oxygen-rich, oxygen-poor. I don't want you using those terms because they're not that accurate. Choose oxygenated blood and deoxygenated blood. So deoxygenated blood is blood that needs oxygen. It's going to go to the lungs to pick up oxygen. Why is it called an artery if it has deoxygenated blood in it? Pardon me? All right, so a lot of people go on the assumption that arteries carry oxygenated blood and veins carry deoxygenated blood. And that's true in about 99% of our vessels. But that's not how they get their name. Arteries take blood away from the heart. Veins bring blood back to the heart. Doesn't matter whether the blood has oxygen or not oxygen. It has to do with the direction of the blood flow. So this is one example. The other one is fetal circulation. Umbilical artery. So if you ever go to a delivery, one of the things we always have to do is, they snip the cord, and then we trim the cord up, and we always look at the cord to make sure that it's an appropriate cord. And when you look at it, it's like that. You can flip it and make it a smiley face at the end. But this is the umbilical vein, which carries oxygenated blood. And you have 2 umbilical arteries, which carry deoxygenated blood. Those are the only 2 examples in the human body where we have the switch. Okay? But it's confusing because I still want you to understand that it's not what's inside the blood vessel that designates its name. It's the direction of blood in the vessel that designates its name. Okay? Now one last thing and then I'll end it for the day. We have the structure that exists between the pulmonary artery and the aorta. Okay, it's a connection. Well, in adult circulation, it's not a connection. It's just a tissue. It's referred to as the ligamentum arteriosus. Now, same way that we had blood that was taking the path of least resistance in fetal circulation, in other words, before the baby came out of mom, remember some of the blood went from the right atrium to the left atrium and then made the rest of the circulation. And that went through the patent foraminal valve. Well, because those lungs are still filled with fluid, not all blood went this way. Some blood came down here to the left or the right ventricle. But then it started going through the pulmonary artery and it's like, woo, lots of resistance down here. Why? Because those lungs are filled with fluid and that fluid is compressing down on the blood vessels that surround the heart, or surround the lungs, okay? So there's a connection between the pulmonary artery and the aorta. And it's referred to as the patent ductus arteriosus. And again, since we're lazy, what are you supposed to call this? A PDA. So when the baby comes out, starts taking breaths, usually if it's a vaginal birth, that fluid is being squeezed from the lungs as it goes down through the canal. Baby starts taking breaths, fills with air, the resistance goes down, the baby starts to oxygenate. This is why if you've ever again been to a delivery, baby starts to pink up when they start taking breaths, because they're oxygenating better. They didn't need to do that before because they were getting their oxygen from mom. So once the oxygen level starts to go up, this starts to close. And then it just turns into connective tissue. So the patent ductus arteriosus becomes the ligamentum arteriosus. And again, roughly, think of the name, arteriosus is in both, so that should help you kind of know that those are the connections. Now this usually, we figure out if it doesn't close, so we'll talk a little bit about what a murmur is when we get farther into the lecture. But this stayed open, you'd hear a murmur. And we'd have to decide which way the blood's going. If the blood goes from left to right, it's not a big deal. If it goes from right to left, it's a big deal. So sometimes we have to go in and actually ligate it, tie it off, so blood is no longer flowing in that area. Any questions on kind of the structure, the growth structure of the heart, the great vessels? Okay, so tomorrow we'll finish up. We'll talk about the different circulations that exist in the heart. Pretty straightforward. We'll go over the blood vessel question. I'll try and post some stuff, so try not to download anything or pull anything off until later on today, unless you're not going to be around a printer. I'll try and see if I can put what I wanted to have on there, but if not, you can automatically print off the blood vessels with sound. That's perfectly fine to print off right now if you want, so you don't